Hello, welcome to Atropia Medic School. Today we're going to go over heart anatomy and physiology. This will be a good review on some of the stuff that we're going to go into in some of the other cardiology quizzes that we'll be doing. All right, so first question. Deoxygenated blood is pumped to the lungs via A, the pulmonary veins, B, the pulmonary arteries, C, vena cava, or D, the aorta. Take a moment to pick an answer. And the correct answer here is going to be B, the pulmonary arteries. Let's do a little bit of review here so that we can get kind of oriented to the heart. Good thing to keep in mind is the NREMT and a lot of EMT tests will ask just straight up anatomy and physiology questions about the heart. So it's a good idea to have a solid understanding of the heart. And a good way of doing this is being able to draw out the heart. And if you can label 90% of it from memory, you should be good to go for the test. So let's trace how blood returns back to the heart, gets pumped out to the lungs, and then returns back to the heart to go systemically. So let's talk about the right side of the heart first. This is what we oftentimes refer to as pulmonary circulation. So if you remember from class, deoxygenated blood is returning back to the heart through all of your veins and eventually coalesces into two big veins. We've got the superior and inferior vena cava. So inferior vena cava is bringing blood from the torso and the legs back up to the heart, whereas the superior vena cava is bringing blood from the arms and the head. Now that deoxygenated blood is going to pass into the right atrium. And that blood is going to get into the right ventricle. It has to pass by the tricuspid valve, right ventricle. And we'll circle here in a different color the valves. So we have the tricuspid valve. One-way valve, that way blood doesn't go backwards. And then when the right ventricle contracts, it's going to pump that blood up through the pulmonary arteries. So the pulmonary arteries, there's one that goes to each lung. This is all deoxygenated blood. So this is kind of our main exception to the rule of arteries carry oxygenated blood, veins carry deoxygenated blood. So all that blood is going to go to the lungs. It's going to go through the alveolar capillary membranes of the alveoli in the lungs. We're going to exchange oxygen and carbon dioxide, and we're going to bring reoxygenated blood back to the heart. And that's going to come back to the left atrium. And it's going to come back to the left atrium via the pulmonary veins. Now, there's two pulmonary veins that come from each lung. And that blood from the left atrium is going to get pumped into the left ventricle. It has to pass by a one-way valve. This one's the mitral valve. That doohickey right there. And then when the left ventricle contracts, it's going to pump that blood through the aortic valve. And then the aortic valve is, getting forced open. That blood's going to go through the aorta, and it's going to get disseminated to the rest of the body. And so when we refer to the left side of the heart as systemic circulation, that's why. Now, I failed to mention one other thing here in that there is a one-way valve also going through the pulmonary arteries. That's the pulmonic valve. And you'll notice that there's these little stringy thingies attached to the mitral and tricuspid valve. And those stringy thingies, these two things right here, those are called chordae tendineae. And they help prevent the tricuspid and mitral valves from flopping back into the atria, because we want to maintain that one-way valve effect. So those help keep them from flopping backwards. They also allow, when the ventricles contract, to return the valves back to their closed position, and when the ventricles relax, it allows them to open up to get passive filling of the ventricles. This is just a very basic outline of the anatomy of the heart. At some point we will talk about the electrophysiology of the heart, but we're going to come back to that in a little bit. All right, next question. The term used to describe the force needed to open the aortic valve and overcome vascular resistance is A, preload, B, the blood pressure, C, afterload, or D, systole. Take a moment to think about your answer. And the correct answer here is going to be afterload. Afterload describes how much, well, as the question states, how much force do we need to actually get blood through all those blood vessels? That's not the same thing as the blood pressure. When we say blood pressure, what we really mean is how much pressure exists during systole, meaning when the heart contracts. So what's the pressure on the blood vessels during systole? And what's the pressure at baseline or diastole? So when the heart's relaxed, that's diastole. When the heart's contracting, that's systole. So diastole is like that baseline pressure, if you will, in the blood vessels. That's in essence kind of what we think of with the afterload. Can we overcome that baseline pressure to be able to get blood going forward? Preload is another important thing to have an idea of about. At the EMT level, it's not super critical to know much about this. At the paramedic level, you'll be expected to know a little bit more about it and how it's important and certain correlations to that. But all preload is how much stuff is coming back to the heart. How much stuff is returning. So what we mean by that is, in preload, in order to fill the ventricles with blood, I have to have blood coming back to the heart, right? And if I don't have very much blood coming back to the heart, that's going to reduce the preload. We know that there's this thing called Frank-Starling's law. And I know we're going on a little bit of a tangent, but we're going to kind of tie this all back here. Frank-Starling's law. And Frank-Starling's law says more stuff, in essence, equals more stretch. So when we get more stuff returning to the heart, the ventricles can stretch more. And when we have more stretch, we get more contraction or more squeeze. So up until a certain point, the more stuff I'm getting in the ventricles, the harder the heart can beat, and the more force we can use to get that blood through the blood vessels. In essence, it allows us to kind of overcome afterload a bit more. Again, blood pressure does this tie into afterload? Yes. If I have a higher resting diastolic blood pressure in the blood vessels, that means that there's going to be more afterload that needs to be overcome, but that doesn't necessarily 100% mean they're not the same thing. Right? Blood pressure is kind of a quantifiable thing. Afterload is more of a concept. Let's just keep it at that. Let's look at the next question now. Which of the following is the primary signal generator for the heart's electrical system? A, SA node, B, AV node, C, Purkinje fibers, or D, Bachman's bundle? So take a second. Think for an answer. And A is going to be our answer. Let's kind of go into more detail about this. Let's go up to another diagram. So there's three structures you need to know at a very basic level for how the heart generates signals, electrical signals. So starting with the SA node, which was the answer here. The SA node is very specific tissue in the kind of in between the right and left ventricles, right and left atria, and it generates a very regular electrical impulse. We know that the adult heart rate is somewhere between 60 and 100 beats per minute, and that's kind of the intrinsic rate of the SA node. Now, the SA node, when it fires these signals, it sends them down kind of electrical pathways. Every single cell in the heart has some level of automaticity, so it can self-generate a signal, and excitability, meaning it can respond to other signals. But there are certain kind of, we'll say, roads, if you will, that the electrical signals do tend to prefer to travel quickly down. There is one that goes across to the left atria, and this is called Bachmann's bundle. This isn't super critical to remember, I'm just kind of highlighting it. But anyways, those signals eventually are going to go down to another part of the electrical system, and it's roughly there. And this is called the AV node. Now, the AV node does two things. First, it has an intrinsic rate of 40 to 60 beats per minute, meaning if it needs to take over as a pacemaker. So let's say the SA node fails, there's nothing in the atria that are creating those signals that we need to regulate every other part of the electrical system, the AV node will take over. It just takes over at a slower rate. Number two, it's also kind of like a signal sorter, if you will. We don't want little signals to get into the ventricles and causing all sorts of weird, we'll say, dysrhythmias to happen. Because like we talked about, the SA node, although like it produces a very strong signal, other parts of the atria can become excitable. They can self-generate their own signals. And we don't want those little signals to hit the AV node every single time and cause that signal to go down to the ventricles. We'd get very confused ventricles. So only strong signals that have enough energy to depolarize the AV node will actually cause it to depolarize. So it's got a couple benefits. Now going down the sides of the septum of the heart, you have your bundle branches. Bundle branches. And eventually those bundle branches terminate into the Purkinje fibers of the ventricles. And that's what causes all that ventricular heart muscle to contract. So Purkinje fibers. Now let's say there's something really, really wrong with your heart, and only the ventricles are really working at this point. Well, they can take over, but it's at an intrinsic rate of like 20 to 40 beats per minute. And that's not very sustainable for very long for obvious reasons. So these patients may precipitate down into one of our lethal dysrhythmias, ventricular tachycardia, ventricular fibrillation, asystole, something along those lines. If you remember the SA node, the AV node, and the Purkinje fibers, those are the most important parts to remember for the purposes of like your EMT exams. There is one other part of the heart I'll mention. There's something kind of just south of the AV node that we call the bundle of His. It's kind of an extension of it. It's not super important for you to remember. That can also generate signals and act as kind of like a backup to the backup for the AV node. Some junctional rhythms going on to like paramedic stuff may be generated by the bundle of His, but that is not super important for our discussion today. Next question. Primary hypertension may lead to the hypertrophy, dilation, or failure of which heart structure? And to be more specific here, one of these structures is going to be most affected by the effects of like hypertension as we see it in older adults, let's say? Is it A, the right atrium, B, the right ventricle, C, the left atrium, or D, the left ventricle? So take a moment, let's think about it. And D, the left ventricle, is going to be our bigger issue. Why is the left ventricle the bigger issue? Well, let's go back up to our diagram here and kind of visualize this. So we know that the left ventricle is it's the bigger of the two ventricles. As you can see here, the ventricular heart muscle is distinctly thicker compared to the right. The left side has to be thicker and more built up in order to pump against all that afterload we talked about, in order to get blood, to your feet and your arms and all the important organs in your body. So it is naturally thicker. It also, imagine that your blood vessels over time are getting harder. They're not as elasticy. Maybe we make some terrible life decisions or don't have, the best lifestyle. And this causes kind of the hardening and the less flexibility of our blood vessels. That's what we refer to as primary hypertension. Are there other causes of hypertension aside from aging and poor lifestyle choices? Yes, not an important discussion here. So imagine now there's a lot more afterload that I have to overcome because my blood pressure is elevated and things like that. Well, I can do a few things to kind of compensate for this, none of which is ultimately super good, but we can compensate for it in a few ways. First off, I could thicken up the left ventricle, right? So I could make it thicker. So we'll just kind of do that in orange here. We can make it thicker, right? That's one potential compensatory mechanism. And there's actually some congenital heart defects where the ventricular heart muscle over on the left side gets super, super thick just as a genetic thing. And that can cause problems. But that's one way we can overcome this. Another one is, especially if we have like valvular issues or other stuff, other times, the left ventricle will start dilating out. Why? Because sometimes you get blood coming back into the ventricle. Other times, because it's so hard to pump it out, we just need to accommodate more blood. In either case, we can actually dilate out the left ventricle. However, over time, both of these things, although they're initially compensatory mechanisms, it'll burn out the left ventricle. And this is why your doctor, if you're, on the older side or you have high blood pressure, kind of really wants to aggressively treat high blood pressure because it causes all sorts of stress on your heart, particularly the left ventricle. Now, can you have issues with your right ventricle? Absolutely. If I have severe pulmonary or respiratory issues, that can put a lot of strain on the blood vessels of the lungs, which in turn the right ventricle has to pump against. So if there's a lot of strain on those blood vessels and they become hard and thick, guess what? The right ventricle is going to go through the same thing. So your poorly controlled asthmatics, COPDers, things like that, those people oftentimes have right ventricular issues, on top of having left ventricular issues because they probably have underlying high blood pressure too. So this is why we kind of get worked up, at least in the clinical setting, about high blood pressure. Now, in the field, what do we consider high blood pressure? Anything, in essence, over 140/90 is going to be considered hypertensive. Now, a patient at 150/90, not complaining of anything, is that a problem? Not for us. That's not anything we're going to deal with. But it's something to note because they may mention a patient has a history of hypertension in a question. Hypertension may not be the issue today. It's the risk factor for all sorts of other heart problems coming up. So that's my little shindig about hypertension. Last but not least, you have a patient with dizziness and chest pain. The heart rate that is 48 and the blood pressure 86/50. All of the following are true except A, the patient is in cardiogenic shock. B, the AV node may be the pacemaker. C, the patient is having a myocardial infarction. Or D, the patient may have a dysrhythmia. take a moment to think about your answer. And the correct answer here is C. So keep in mind that we were asking kind of a negatory question. One of these things is not true. Which one is it? We cannot prove that this patient is having a myocardial infarction, not without doing either an EKG or getting a whole bunch of blood work. But it is reasonable to suggest that given the blood pressure and the heart rate being all sorts of off, it is reasonable to suggest that the patient may be in cardiogenic shock, or probably is in cardiogenic shock, given the complaint. The AV node may be the pacemaker. Again, the intrinsic rate of the AV node is between 40 and 60. Heart rate's 48. It is reasonable to think that this may be a possibility. And it may be reasonable to think, too, that, well, if their heart rate's 48, we can't necessarily, without an EKG diagnose an abnormal rhythm. But it is reasonable to suggest, given the rate, that there may be a dysrhythmia. We can't prove it 100%, but given that they say may, we don't have to, it just has to be a suspicion. Keep on the lookout for stuff like that. A lot of times if they want for questions like this, they may or may not give you some language making one of these things super definitive, like 100% true all the time, and the other ones are like, this is a possibility. So just a test-taking pearl to keep in mind. That finishes up all our questions for this board. If you have comments, suggestions on how to improve the quality of these videos, absolutely leave a comment, like, and subscribe, and we'll see you next time.